I have a question.
Yes,
If I could just mute myself here.
I can hear you.
Okay, great. Um, so you talked about these carb alternatives. Uh,
Mhm.
Oftentimes we look at those and it seems as though they have almost the same amount of carbs as the regular carbs. What makes them better?
So some of the carb alternatives, especially the darker ones. So for example, if we're talking about the difference between having potatoes and a sweet potatoes, it's not a fast carb, it's more of a starch, so it's slower absorption. And so it doesn't cause a lot of spikes in your blood sugars. So that's where those would be a better option. So, for example, when you have something that's really sugary or that's like a fast carbohydrate, so the fast carbohydrates tend to be like the whiter carbohydrates, your blood sugar spikes up. And then your body's reaction to that is that it wants to secrete insulin and it tries to take this insulin out of your your bloodstream and turn it into fat. And so then it turns it into fat and it moves it into your muscles and your fat cells. And so then you get that feeling of low blood sugar, or at least you don't have as much circulating blood sugar, and that makes you want to have something sweet or some carbohydrate. So a good example is when you go to have Chinese food or sushi, which tends to have a lot of rice. You eat, you feel full, you're like, oh, okay, great, I'm not going to be hungry for a few hours, and an hour or two later your body has now moved that sugar into your fat cells and your muscles, and now all of a sudden you're hungry and you're craving something sugary again. So we want to get the starches or the other alternatives that will give you a more even blood sugar level, so they're not spiking it. And this way you're less likely to have these ups and downs that will make you crave or reach for more sugar, and your body isn't basically fighting to push and create fat or break down fat when your blood sugars go down.
Gotcha. So it's really about the spikes then.
Yeah.
That very rapid spike. So,
Mhm.
I have heard of wheat bread, at least
Mhm.
in North America, being one of those good alternatives to just regular white bread. But then there's also a group of people who say that the way that wheat is processed in North America doesn't make it a good option. Can you shed any light on that at all?
So, you know, it's one of those things where we're eating processed foods anyway. It's not like we're in, Europe or in Africa where your bread is probably being made and processed on the same day. I don't know much about how it's truly being processed in America versus in other places. That being said, we do know that the American diet is very processed. And so a good example I will tell you is I have patients who live in Europe, and whenever they go to Europe for vacation for a few months, they always tell me that they're somehow able to eat pasta, regular pasta, and they're somehow able to eat bread every day, and they're able to lose weight and not gain weight. But when they're in the US, they would have pasta and bread, and their weight will just spike up. So they don't eat any of those things here in the US, but in Europe they're somehow able to eat those. And essentially they're like, it's the same thing. Why does that happen? So there definitely has a lot to do with the quality of the products. So probably their products are just better. The amount of time that they've probably been kept before being processed, and whatever the processing procedures we're doing, or whatever the chemicals that we're adding that make it just a not so good option. So a lot of it has to do with just the processed lifestyle that we're leading here in the US versus if we were somewhere else.
Yeah, I've heard the same thing from friends in Europe. Thank you. It's been very insightful.
Yeah, that was a very good question. And yeah, like I mentioned, sometimes we don't necessarily have to make such drastic changes. Everybody always, whenever we encounter this type of diagnosis, the initial reaction is I have to change everything. But really, we just have to pick the things that are in line with our lifestyle. So, and that's why I mentioned about like staples. So like, I do have patients who, for example, are either Asian or African, and it's really hard for them to not have carbohydrates. And so a better thing for them would be to continue their white rice or to continue bread or whatever, but just have a much smaller portion. Like it doesn't have to be the big part of your meal. So if you would usually have a plate that has rice and like 1 or 2 pieces of meat or fish, maybe we reverse that and we have a bigger piece of fish, meat, protein, tofu, whatever it is that we're having as our protein, and a small portion of that rice. So a lot of times when I start working with my patients, I actually have them change the order that they're eating, and it tends to work really well. I have them eat the protein first, then I have them do their fruits and vegetables, then I have them do their carbohydrates at the very end. So hopefully by the time you're getting to the carbohydrates, you're already feeling full, and hence you would eat much smaller portion. The other thing I recommend is just eating in a smaller plate. So sometimes, visually, if you have a big plate and a small portion, your brain can trick you into thinking that you're not full or that you're not satisfied. If you have a smaller plate and whatever you put on looks a little bit more like a heap, your brain might actually go, oh, that's a lot of food. And so you would be eating it, and it would be sending messages to your brain that, hey, I'm eating a lot, I'm almost full. So sometimes we need these little tricks and strategies to help us, even though, we know that we're tricking ourselves, but the brain works in a very funny way. And so sometimes we just need to give it time to catch up. The signal to let you know that you are full actually comes about 15 to 20 minutes after you're eating. So by the time you get the signal, you might have already overeaten or really stuffed yourself. So eating in a smaller plate can be helpful, and just assuming, hey, I am gonna serve myself 70% of whatever I would usually eat. So if you do need a second helping, then you're maybe eating the same amount. But if you don't need a second helping and you get full, then you've just saved yourself 30% of what you would have eaten just because it was on your plate.
Thank you.
Yeah, thank you.
Yeah, I have a comment to make. Firstly, let me say a big thank you to you for that brilliant talk. Very, very brilliant. Well done.
Thank you.
The comment drawn from my experience practicing medicine in Nigeria. When you talk about lifestyle changes and the diet as well, we find it very difficult to get patients in Nigeria to adapt to this one, particularly the diet. Reason is because our diet in Nigeria is significantly, almost 100% heavy fatty meals. Talk about the pounded yam, the eba, and all of this. With very little vegetable in the soup. And people tend to load up everything. We eat heavy.
Mostly Hispanic population. The diet is very heavy in, potatoes, plantains, rice, bread, a lot of yuca, lots of starches. So even though they have some of their, starches that last a long time, they still are very, very likely to progress to diabetes just because of the volume of carbohydrates and the volume of sugary things. We're drinking like Malta, India, and anytime you're sick, anytime you have low blood sugar, it's a very constant staple, and that is just a lot of sugar. So in working with, that population, I did see that even with starting people on metformin or starting them on medication to prevent diabetes, that they will progress. And that a lot of it has to do with, not being able to make those lifestyle changes, but also has a lot to do with attitude too, right? And that's why I usually like to focus on lifestyle. Even if I have patients taking medications, because I tell them the medication can only do so much. We have to help the medication help you, because if you're not helping the medication, then it has no business helping you at all. It's just as simple as that. You're just taking it because you wish to take it, but we have to do our part in order for the medications to work and in order for us to get to a goal. So I think the main thing is, one, recognizing that this is something that can be changed. And that's why I want to reframe that point of view that it's a terrible diagnosis. It is, we don't want you to have prediabetes, but once you have been diagnosed with that, this is a good thing. Now let's work on fixing it. Let's take it in the other direction. It's better to know before. You know, you could have anywhere from like 5, 6, 8 years before. Even if we just kept you at that pre-diabetes diagnosis and you didn't progress to diabetes, that is a win. Ideally, we want to reverse it and take you further away from it. However, if we keep you in the low pre-diabetic range, that is still very helpful, and that would extend your lifestyle, your lifespan anyway. So I do have a lot of patients, like I mentioned, from just different backgrounds and nationality. I do have a lot of patients who are Africans, and I do have a lot of patients who are Asians as well. Depending on, you know, their age. So if they're younger, I find that it may be a little bit easier to work on, you know, lifestyle changes, just because they know what to do, they're savvy, they're on the internet. If they're a little bit older and stuck in their ways, now we're trying to have somebody who's been eating a certain way for 60 years to suddenly change, and we're not giving them, you know, a good enough reason, right? So I think one of it is just like the intent and, you know, the benefit. Well, what is the benefit you will get from not being diabetic? And if they don't see that as a possibility, then there's no impetus to change. The other thing is, rather than just simply saying, you need to stop doing this, this, and this, giving them actionable things, actual options. So I've been guilty of this when I worked in primary care. I had my spiel that I told everybody who came in and they were diabetics. I'm like, no coma plátano, no coma yame, yuca. I had like a list of things that I would tell people: don't eat plantains, don't eat bread, don't eat rice. And I would just, you know, spill it off quickly and say, yeah, and I'll see you in 3 months. Goodbye. But if I tell people don't eat all these things, but I don't tell you what to eat, then you're going to go home and go, oh, well, what am I supposed to eat? Well, I don't know. And then you go back to doing what you're supposed to do. So if we can frame it in a way where we have options that are available to them, options they would actually consider, then I think that would be a much easier way to get these patients to follow or to make these changes, right? So rather than saying don't eat these things, we may want to frame it as, how about instead of eating this, we try this? And the other thing I will say is that we can't give people too many options. So we can't say change all these different things right away. It's just not going to happen. You're going to feel frustrated. You're going to feel overwhelmed. It's going to be hard to know where to start. So one of the things that we do as part of our clinic is that we have frequent meetings with patients. So we're meeting with our patients every 4 to 6 weeks. As they progress and they're better, then we're doing it every 8 to 10 weeks. It all depends on what their goals are. But initially, we want to come up with, I tell people, either 1 or 2 things that you know you can do well. And then let's take the time to do those things well. Let that become a part of your daily habit. They say it takes 21 days to build a habit. Probably does take more than that, but let's assume 21 days they need, right? Let's do those things well. Let's get it involved in our habit so that we're not thinking about it now. And then let's meet again and let's figure out another 2 to 3 things that you could do and you can action. So I think setting small but reasonable goals is actually the way to go, because then they are now responsible for 1 thing or 2 things. When you follow up, you can say, okay, last time we talked about not eating this, or we talked about reducing your soda intake, or we talked about instead of eating yam, you are going to be doing sweet potatoes. We can actually action these things and ask specifically, rather than saying, are you eating less carbohydrates? Guess what they're going to say? They're going to say, yes, I'm eating less carbohydrates. I didn't eat carbohydrates yesterday. That's less than what I did the month before. So if we have very specific things that we can ask and like really point out, then it's easier for us as us on the physician end to then determine what the patient is doing. And it's easy for the patient because they only have to think about one or two things. All I have to do this month is drink more water. All I have to do this month is eat to 70%. All I have to do is eat my protein first and then do. So we want to have it very simple so that it's really obvious what you have to do, and then they can go from there. Then you meet up, you reassess. If they're doing well on one thing, let's continue down that route. If they're not doing well on that thing, then maybe that's not the thing that they should be focusing on right now. So we don't want to set people up for failure. And I think that maybe just having that approach of like close, follow up, and then setting actionable things, like let it be really obvious what we want the patient to do so that they can then go and do it. And they can report back as to whether they have been successful or they have failed. And then making it open for discussion where it doesn't feel like, oh, I can't tell my doctor that I didn't do what was supposed to be done. Because if we're assuming that the patient is doing what they're supposed to do, but they're actually not, it's also not a good situation for anybody. So making sure that it's an open environment where you feel comfortable telling your doctor what you're doing or how hard it is for you to do something. And if you're not really that comfortable telling your doctor that, then you probably need to find somebody else where you have that level of confidence that you can have an open discussion. So I think that those are some of the things that we could probably implement, just to make it easier for those patients. Now, obviously, this does not mean that everybody who is pre-diabetic, we're just going to barge in there and fix. Sometimes some people will progress no matter what we do. And at that point, we will be just managing the diabetes. But for those people that we can certainly take out of that waiting room and send them off on a different direction in their life, hopefully, we're able to do so by guiding them appropriately with these slight lifestyle changes, and hopefully that will be helpful. Okay, so it was great having this discussion. We are at the end of our time. I look forward to having more of these talks and educating everybody on different things that are related to metabolic health and weight.